Hello everyone and welcome to today's Elsevier live webinar, Revision for Medical Students, Core Topics for Clinical Practice. This session will consider core areas which will help you study at medical school and those which are really clinically relevant for practice as a junior doctor. And the session itself today will be about 20 to 25 minutes long, and we should have some time for questions at the end. So please do drop those into the Q&A box as you think of them throughout the presentation. So taking us on this journey today is Dr Alasdair Anderson, who you should be able to see next to me on the screen, and he's a junior doctor in the northeast of England. Alasdair has a huge amount of experience in mentoring students and a really keen interest in medical education and leadership. So it's great to have you with us today, Alasdair. Thank you ever so much for taking the time out of your schedule to speak to everyone, and we look forward to hearing you talk. So I think the best thing for me to do is hand straight over to Alasdair. Thank you, Alasdair.
Lovely. Thank you very much, Debs, and thank you very much, everybody, for joining me today. So today I'm going to talk a little bit about revision for medical students and some core topics for clinical practice. Now, it's not going to be an exhaustive list of everything you need to know by any means. It's just considering a few core concepts and things to think about that will help you develop your own approach to how you're going to learn at medical school. So I'll do a very quick overview of learning styles, and I'll consider some essential areas of medicine which are really useful for being a student, quite often come up in exams, but also really, really vitally important for being a doctor too. So we'll have a think about surface anatomy, we'll have a think about history and examination, we'll have a think about managing acute illness as well. We'll consider some resources, and we'll have some time for some questions at the end of the session as well. So there's lots and lots of information to learn at medical school, and it comes at us in very different ways. Some of it is visual, so videos or presentations, pictures in books. Some of it we listen to, it comes in podcasts, it comes in talks. Some of it is feeling, so we might be in an anatomy lab or we might be dealing with models. And some of it is about reflective, where we think about, we do an activity, we read about something, and then we think about how we apply it in a real world situation and how we can apply that to be a doctor. Actually, we all learn in very different ways in different situations. And in the real world, we're quite often combining these styles when we're learning at medical school. And it's about being aware of which styles you're comfortable with and which styles you need to develop to study better at medical school. It's really important to work with other people, partly because there's lots and lots of information at medical school, but also because different people learn in different ways. And if you help each other to combine different styles of learning, overall, it can really lead to good outcomes for group learning. It's also really important to get plenty of rest and consider your well-being when you're doing revision for examinations. It can be really easy to fall into the trap of doing 8, 10, 12-hour revision sessions, not eating properly, not drinking enough fluids. Really important to build in rest times, and quite often it's better to do an hour or two's revision, then have a 10-minute break, and then do another hour or two's revision. Chunk it up rather than spending massive amounts of time. And I promise you, it'll go into your brain better, you'll retain it, and you'll be calmer at the end of it. If you do have any stresses or any sort of big anxieties about things, talk to somebody about it, whether you talk to friends or whether you talk to tutors at the university. Talk about it before it becomes a big problem. So the first area that I'd like to consider is surface anatomy. So why am I talking about surface anatomy? Why is it important? It's important because it links in with the core procedures that you're going to be doing as a junior doctor. And these are things that are examined at medical school. So you might start out doing arterial blood gases, taking bloods, doing NG tubes and doing cannulas on models. But actually, sooner or later, you'll be doing them on patients, and you need to be able to do them safely. And you need an awareness of the surface anatomy in order to do these procedures safely. So, very commonly assessed areas in examinations are the boundaries of and contents of particular anatomical regions. So have a look at the cubital fossa, particularly in related to taking blood and cannulas. Think about the carpal tunnel and the anatomical snuff box in relation to damage to those areas and what tenderness in the anatomical snuff box might represent. Think about the axilla region, particularly safe triangles for inserting tubes. And also think about the extensor tendon compartments of the wrist and how damaging particular areas can impact on the clinical presentation of people. So I'm not going to give you all the answers. Go away and have a look at these areas because they're really, really important. And another thing that often comes up is surface anatomy for lumbar punctures, and also thinking about the layers that you would push a needle through in order to perform the procedure. You might not do a lumbar puncture as a medical student or as a first year junior doctor, but depending on which training route you take, you might well be doing it later in your career. So it's important to know the anatomy well and know how to do the procedure safely. The second one is history and examination. Now, you don't really need me to tell you how important it is to be able to take a good history and do a good examination. The purpose of the history is to formulate an account of the patient's symptoms so that you can start to think about what your differential diagnoses are. So you can start to think, what's the patient in front of me likely to be coming in with? What questions do I need to ask? What do I need to include? And what do I need to exclude as possibilities? And that helps inform your examination, but also the tests that you order afterwards to help diagnose the condition. It's really important to build rapport with the patient. Are they relaxed? Are they anxious? Are they worried? Are they tearful about something? Put them at ease and try and understand their concerns. And also, when you're doing history, think about it in the context of the patient. So can the patient communicate well? Is it difficult for them to communicate for some reason? So they might have a particular sort of problem cognitively. So for example, a patient with dementia, you might need to communicate with them slightly differently. Think about risk factors for particular conditions, and also think about how their presentation relates to their life and relate it to them. So when we're doing history, think about the presenting complaint. Why have they come in? Quite often patients have multiple presenting complaints. Try and find out what the key presenting complaint is. What is the thing that has tipped that balance to make them come into hospital or to see you as a doctor in the community? The history of presenting complaint is all about characterizing that and finding out more information about that presentation. As part of that, you want to do a systems review. So you want to start to think about how the patient is generally, but also any particular red flag symptoms. So if I give you an example of a presenting complaint of chest pain, in the history of presenting complaint, you might want to start to take a structured approach to characterizing that pain. And these are the sorts of questions that can come up in written examinations as well as practical examinations, because they want to understand that you know how to take a history and you understand the reasons you want to take a history. And they're obviously vital for being a junior doctor too. So presenting complaint, chest pain, history of presenting complaint. We can take this Socrates structured approach. So where's the chest pain? Get them to point. Is it central? Is it a crushing chest pain that comes on quickly? So we've thought about our onset and we've thought about our character. Does the pain radiate somewhere? Does it go into the jaw? Does it go down the arm? And is it associated with any other symptoms? So do they have any nausea? Do they have any vomiting? Are they cold and clammy and generally feeling really, really unwell? When did the pain come on? A pain that's been there for weeks might not be so concerning as a crushing, strong central chest pain that's been there for 15, 20 minutes. Does anything make the pain better or worse? And throughout this all, is it a very severe pain on a scale of 1 to 10? Is it a 10 out of 10, the worst they've ever felt? Or is it not a very strong pain at all, but is bothering them for other reasons? And while you're thinking about doing the history of presenting complaint, systems review, think about red flags as well. So with chest pain, your red flags might be crushing central chest pain, those associated symptoms of nausea, vomiting, clamminess, dizziness. The red flags are going to vary depending on the system that you're asking about. So headache red flags, sudden, under 5 minutes onset, worst they've ever felt, like being hit over the back of the head. Your red flags are going to vary depending on the system, but it's important to have in your mind a structured approach so you can add the systems review and the red flags in to the particular presenting complaint. Past medical history, really important to get a good past medical history. So this patient with chest pain, do they have a previous history of heart problems? Do they have a previous history of lung problems? And with family history, we're thinking about, in this case, okay, so their father had a heart attack when he was young, when he was 36. Okay, so there's strong cardiac risk factors there. Medications and allergies, really important to ask medications. If you think about the patient who might not have taken their medication for a couple of weeks because they're worried about the side effects, that might be impacting on why they're coming in with chest pain. Medications is a really good point to start to think about any supplements that people might take and their ideas, their concerns, and their expectations about their medications as well. So allergies are really important to ask, because anything you might prescribe, you need to know about, you need to know that it's safe to give. And then finally, social history. So home life, do they live alone? Are they working at the moment? Do they drink alcohol? Do they smoke? Have they traveled recently? And you can see how different questions are going to fit into different systems, but you can still have this structured approach. The reason I've put it in a grid like that is to start to have a simple approach so you can take that grid and draw it out in an examination or have it in your mind so that you can run through those areas when you do it in real life. Throughout all of this history taking, you want to connect with the patient and you want to understand, I've used that term, ideas, concerns, and expectations. And really it's personal to you where you put that in, but it's important to understand what ideas the patient has about their particular condition, what in particular is concerning them, why they've come to see the doctor, and also what they feel could be done to help. If you can understand what's worrying the patient, you can put them at ease and address their concerns. Now, you don't need me to go through all of the bits and pieces of the general examination. It's something that you do a lot at medical school, and it's something that you can practice with your friends when you're at medical school. However, it's important to have a structured approach. Get good at doing a general examination. Remember to always look at the patient and take that inspect, palpate, percuss, auscultate approach. Once you're good at doing a basic general examination, then you can start to build into it specific examinations like a cardiac examination or a chest examination or a musculoskeletal examination. But it's really important to get the basics right and build on them. It's also really important to remember a couple of things, not just for exams, but also for being a doctor. You will get and lose marks if you don't wash your hands properly. You need to make sure that you wash your hands properly. And that particularly goes in the clinical setting now with everything that's going on with COVID. It's really important to get hand hygiene and also personal protective equipment right. Also, look at the patient in front of you. So the signs that we talk about in the nails, for example, you might have a patient who has a particular tattoo that gives a clue as to what condition they've got. You might have a patient who is wearing a medic alert bracelet or medic alert necklace. And you might have a patient who has self-harm scars. It's also important when you're looking at a patient and having that initial contact with the patient to start to think, actually, are they confused? Are they alert? Are they conversant? And you can start characterizing your GCS, or your Glasgow Coma Scale score early on. And the last area that I wanted to touch on was acute illness. Now, in different countries, it'll be managed in slightly different ways, but I wanted to share the approach that we use in the UK and just give you some resources so you could check it out. It's an important area for being a doctor, but it's also something, again, that's important for being a student, because you want to be in a position where you understand it well. And if you encounter a patient who's really unwell on the ward, then you know the basic things to do, and you know how to escalate that appropriately to a doctor who can manage the patient. So in the UK, it's the Resuscitation Council that we use to guide how we deal with the acutely unwell patient, but also with cardiac arrest situations. And I'd really urge you to have a look at the resources from the Resus Council, which are up here on the screen, but also resources that might be in your own area or your own country as well. But it's really important to get used to using a structured approach. So first of all, you're thinking about the airway. Is there an obstruction to the airway? Do I need to do some airway maneuvers? Is the patient not breathing? I need to summon some help. When we're doing the observations on the patient, so the respirate's raised, the patient's cyanotic, their saturations are low, let's get some oxygen on them. Okay, so their pulse is really fast. Their blood pressure is very low. Let's get some fluid into them. Let's get an ECG. Let's start to have a think about what might be going on. Okay, so the patient is not very alert. They don't have a GCS of 15. Why could that be going on? Do we need to order an urgent head CT? Do we need to check their blood sugar to make sure that they're not hypoglycemic? And exposure. Do we need to start to look for injuries? Is the patient bleeding somewhere and we haven't checked them out? So really important area, commonly assessed, but also something you will encounter a lot as a junior doctor. And I just wanted to quickly share a few resources as well. So there's lots of different books that can help and lots of different learning styles. So some people reading in a book and seeing images in a book are really, really going to help. It's going to be the best thing. Books give you lots and lots of information, sometimes an overwhelming amount of information. So be careful about how much time you spend, pick out the relevant things. Practical experience is absolutely the best thing when you can do it. It can be quite tricky to do it at the moment, particularly with COVID situation, but there's an awful lot of online resources. Remember, some online resources are better than others, and you need to pick that information that you use carefully and well to make sure that you're getting good quality information. And also remember that you can do a lot of group work and peer learning. So there's a lot of opportunities to do quizzes, for example. There's a lot of opportunity to test each other on surface anatomy as well. So lots and lots of things that you can do electronically, even if you can't get into the hospitals and do everything practically with your colleagues. So thank you very much for your time. I've had a little bit of an overview of learning styles. I've covered very quickly 3 essential areas for medical students. I've shared some quick resources, and we've now got a little bit of time for questions. So thank you very much for your time today.
Thank you very much, Alasdair. We do have some questions coming through. We've got a question about cardiac infections. So the question is, what about cardiac infections?
That's an interesting question.
In relation to history taking.
So quite often there's something that someone's been vaguely unwell for months and months and months, and it's not necessarily being picked up on. So they might have ongoing temperatures, ongoing shortness of breath. They don't feel quite right. There might even be some element of weight loss. So they tend to be quite vague histories. So I think that's where a systems review comes in. Quite often, if someone's got something like endocarditis, it often isn't a sort of first-line diagnosis. People might think, oh, they've got a urine infection or a chest infection first.
Mm-hmm.
So I think it's really important with cardiac infections to get that systems review right and do a really good examination, because you might not find anything specific in the history, but then suddenly they've got a murmur when you listen to their heart and they haven't had that before.
Thank you, Alasdair. So we've got another question here. This is probably quite pertinent for a lot of people on the call. Since we can't get onto wards to access patients or models, is there a way you would recommend practicing these skills?
Yeah, I mean, I absolutely think that you need to test each other and not be, I don't mean mean, but just test each other properly. Don't, you know, you've got your friends, you can chat to your friends, but actually come up with sort of challenging questions and challenging scenarios and think a bit like an examiner. And I think that's the best way to do it. So you can't necessarily practice your phlebotomy and your arterial blood gases, right? Medical schools know that. So you're not necessarily going to get assessed in the same way if you can't physically go and do these things on models. But you can certainly talk about the surface anatomy. You can certainly use skin safe markers and sort of mark out where you'd go and draw on some of the surface anatomy. That's all very, very doable. And I found at medical school, quizzes worked really, really well.
Thank you, Alasdair. Some practical tips there, especially the kind of drawing on each other. Another question, what about practicing examination in countries with low cost? Not actually, this is from Ulrich. I'm not sure what low cost, maybe in low income countries?
I mean, the thing about clinical examination is it doesn't have to be an expensive thing to do. I mean, there's an awful lot that you can learn just by looking at a patient and doing the basic things, and that doesn't necessarily need a lot of equipment at all. So a lot of walking in and seeing a patient is, do they look well? Do they look unwell? What equipment is around them? I can feel their pulse. Okay, their pulse feels really rapid and actually quite weak and thready. So you know that they're going to be unwell. You know, just standing in front of a patient, are they wheezing? Do they look obviously short of breath? Are they unable to complete sentences? There's all sorts of things that you can do before you've even considered picking up a stethoscope or getting a piece of a specialized equipment.
Okay, thank you, Alasdair. There are a couple of other questions here. First of all, starting with a compliment, thank you for this amazing session. And then the question is, I've heard of some websites like BMJ Learning. Would you recommend them? Oh, and there's and an anatomy TV. Would you recommend them?
I've not tried Anatomy TV. BMJ Learning looks quite good. I would just see what works for you. Essentially, it's quite a sort of crowded marketplace. There's a lot of stuff out there, and you've got to make sure that you get good quality stuff. That's the important thing. So get good quality stuff. BMJ is always a good, solid sort of resource, but have a look, because you've always got those trusted sources. You've got your textbooks and things like that where you can sort of say, okay, this looks like a good source of information, I'll trust it. And I think that's the thing, be guided by the trusted sources and then see what else is out there.
So Alasdair, would you recommend potentially taking a trial of something? So for example, we have a product called Complete Anatomy, which is an app, a 3D anatomy app, but you can take a trial for a short period before you decide whether it's something you want to purchase. So that could be another option.
I think trials are always a good thing as a student.
Yeah, absolutely. Another question here. How do I persuade a patient to practice a technique on them? For example, taking their blood when you've not practiced a lot in the past and you're not sure you'll succeed. That's an interesting one.
Number one, make sure that you've actually been signed off by the medical school and that you're competent to do it. When you've been signed off by the med school and you're actually allowed to do it, then do it with some supervision. The first time you do it, just ask a junior doctor to go and keep an eye on you and do the procedure with you. Actually, I found that patients are fine about it for the most part. If you just introduce yourself nicely and say you're a medical student, you'd like to take some blood, you've got a colleague with you who's more experienced, so if there were anything, if you weren't able to do it, then you've got a colleague who could do it. But I think just be open and honest with patients and explain things, and absolutely, I've not had a patient refuse me, certainly when I was a student. So yeah.
So would you actually suggest that you should tell the patient that you've never done it before? Personally, I think that's not going to fill them with a huge amount of confidence.
The way I used to do it, actually, I used to say, one of the medical students, I'd like to take some blood. I've got some supervision. I wouldn't necessarily say it was my first time, but I don't think there's a right or wrong there. I think it's just about making sure that you're safe and that you've got some supervision at hand.
Sure. Good point, Alasdair. So I have another question here. We've still got some time if anyone wants to drop any more questions in. Kindly share a guide on study time management that maximizes content mastery. So I guess that's more about how do you make the most out of your time to get the best results? And that's quite a broad question.
Yeah, it depends how you like to do it. I mean, I used to do spreadsheets, and I would say, so these are the topics that I need to learn. These are the ones that I feel comfortable with. So let's put the ones I feel more comfortable with to one side, and let's tackle the things that I'm really uncomfortable with. As a student, it's really tempting to kind of ignore all the difficult things that you don't like doing. But they're the things that typically will catch you out in an examination. And actually, you need to know it well for being a doctor, so you might as well do it properly at med school. So I would suggest that you list out the topics or have a look through your curriculum, find the topics that you feel uncomfortable with and concentrate on those, and then take more of a revision approach to the things that you feel more comfortable with. That's quite a good way of managing your time, I think.
Oh, that's great advice, I think. Next question. This is a nice question. Hey, greetings from India. It would be nice if you could describe to us about your first day at clinical practice. Can you remember, Alasdair?
Yes, I can. So my first job was vascular surgery, and I was terrified in case somebody got really, really sick, because in vascular surgery, when people get sick, they get sick very quickly because they're a group of patients who tend to have lots of vascular compromise. And actually, no one got really sick, which was good. And it was really all the routine stuff. So we had a very quick ward round in the morning, lots of taking bloods, lots of chasing up various sort of tests on the ward. And I think what surprised me was just how much communication with patients and with relatives that I was doing as a first day junior doctor. Because you get relatives who are worried about the sort of vascular risk factor or worried about the risk of amputation for a relative. So I think my top tips would be good at the basics, but also be really good at the communication side of things, because you might find day one as a junior doctor that you do get a relative asking you, okay, so my father's having a AAA repair, what does that involve? You don't always have to have the answer, you just have to be able to answer if you can, or say, actually, I'm not sure what the exact answer is, but I'll find out and I'll come back to you.
Great, thank you, Alasdair. And then we've got another question here. This may need to be the last one because we're coming to time. So the question is, history on the emergency unit. How analytical do we have to be? Oh, and thank you for the session.
Oh, thank you very much. It's your personal approach. I tend to be quite analytical, so I like to ask about important positive and negative in the history. Some people don't quite take the same approach, but I'm quite analytical in the way that I do it. I find that helps in the emergency department because it helps me characterize things. Is somebody coming in with something I'm worried about and I think is serious and we need to move them to a different, more acute area of A&E, or we definitely need to bring them in with these symptoms, versus this person's more likely to be able to go home if the examination and all the tests are okay. So I think it's really personal preference. And it's experience as well, because I think as you get more experienced in emergency medicine, you can do that process much quicker as well, but that takes quite a lot of professional experience.
Mm-hmm. Well, thank you ever so much, Alasdair. We've just come to time. We do have a couple more questions left, but we are at 1:30, so apologies to anyone whose questions we couldn't get to today. We hope you enjoyed the session, and big thanks to everyone for joining, and also to you, Alasdair. I think that was a really interesting, very practical session for the students out there. Thank you very much.
Thank you very much, everyone, for joining.
Thank you. Bye.